So, good evening, everybody. Hope you're all well and thanks for joining us today. My name is Claire and I'm going to be facilitating tonight's talk with our expert, Dr. Joe Lanario, who I'll introduce fully in a minute. Um, First of all, just wanted to say thanks for joining us on this series of easy to understand online talks about health research being carried out at the NIHR Birmingham Biomedical Research Centre. Today's talk will provide an overview of health and care research, including what it is and why we do it. But there'll be lots of other talks coming up in future months, and we've had lots already. We've been doing one every month that you can watch back on our website if you're interested. And we'll tell you a little bit more about the next talk that we've got coming up at the end of this session. So before I hand you over to Joe, I wanted to tell you a little bit about what the Birmingham Biomedical Research Centre is. So we are a collaboration between universities and the NHS. We're managed by University Hospitals Birmingham NHS Foundation Trust, and that's in partnership with the University of Birmingham, along with all of the other partners that you can see popping up on the screen there. We're publicly funded by the National Institute for Health and Care Research, which is the NIHR acronym that you see in our logo. And that's the research arm of the NHS. And we're not the only biomedical research centre. There are 20 of them like ours across England, and they're all working to improve people's health. So at our research centre, we have doctors, nurses, and other healthcare staff who all work together with our researchers to take new scientific discoveries that are found in science laboratories and to turn them into diagnostics. So things like tests or procedures which help to identify illness and injury and treatments. And our research specifically focuses on the causes, effects, and treatment of inflammation. And inflammation is a normal part of the healing process. And we've all probably experienced inflammation at some point in our lives, either as pain or swelling, or heat or loss of function or movement, for example. But sometimes the body overreacts, and too much inflammation can cause lots of other problems. And it's linked with lots of different health conditions, such as arthritis, infectious diseases, diabetes, and cancer. Now, last thing to say before I hand over to Joe, during tonight's presentation, we'd really like to hear from you. So just a quick reminder that if you would like to ask any questions to our expert, you can do that using the Q&A function, which should be at the bottom of your screen. It depends on the layout of your Zoom setup. Sometimes it's at the bottom, sometimes it's at the top. But you should see a little Q&A icon like you can see on the screen. So if you click on that, you can ask questions at any time. And then we will select questions to ask to Joe at the end of the session. If we get lots of questions, we'll try and pick the most popular ones, but we'll get through as many as we can in the hour that we've got. And just a reminder that we aren't able to offer any medical advice tonight, so avoid any questions that might touch on that. And also to say that the webinar is being recorded, and we'll share the recording with you after the talk, so you can watch it back or you can share it with others if they couldn't attend it today. So on to the main event. So just first of all, wanted to introduce our speaker. So Dr. Joe Lanario is a research fellow at the Centre for Patient-Reported Outcomes Research at the University of Birmingham, and is a member of the NIHR Birmingham Biomedical Research Centre's Patient-Reported Outcomes Research Team. It's a bit of a mouthful. Joe's research has focused on the perspectives of patients with respiratory disease and how to support patient-centred care. Joe now works in the Centre for Patient-Reported Outcomes Research and is funded through the Patient-Reported Outcomes theme of the BRC. In the BRC, Joe's current work focuses on identifying problems that prevent participation in questionnaire research, working with people to find solutions and encourage participation. So without further ado, I will hand over to you, Joe, to take us through tonight's presentation. Thanks very much.
Great. No, thanks, Claire. That's a really nice introduction. Great. Well, thank you everyone for coming. I mean, the longer I work at the BRC, the more I realise the amount of effort that goes into presenting or preparing and organising these presentations. Claire, I think you've got a Word document up on the screen at the moment. Do you want to take control and minimise that one? All good. Thank you very much. So before I get started, thank you very much to Claire, Becky, and Laura for organising this and encouraging me to present, but also to Freen, who I believe advertised this talk through her own channels. So no, thank you very much. So Claire's already covered the title of the talk, so I won't cover that again. But I will start by saying this is not an exhaustive explanation of all the parts that go into research. This is simply a broad overview and to start a conversation with people that don't necessarily know much about research, but are curious. Let's see if I can get this slide to move forward. That's always the difficult bit. There we go. Right. So some context so you know where my thinking is coming from. So why this talk and why not something else? So recently completed a survey with over 1,000 patients in NHS outpatient clinics. Of the 950 people who responded to these two questions, 45% had not taken part in research before. 76% did not know someone who had taken part in research before. Now, some of you might not find that surprising. For the first bullet point, I did. That's because we recruited from very research active hospitals around Birmingham, hospitals that encourage their staff to have research as part of their job descriptions. You go into the clinics, and you can see on the walls all the laminated signs advertising the research. So to still have 45% have not taken part in research before, except for the survey I recruited them for, um, was a surprise. So this indicates to me that there is a large portions of society out there that don't take part in research. Now, the second bullet point is an interesting one. 76% did not know someone who had taken part in research before. Now, you may be thinking, when do you sit down with a friend or family member and ask them, or have you taken part in research this week? That might be the case, but again, that indicates that we don't necessarily talk about research casually. And that may be one of the reasons why people are wary about taking part because it's unknown, it's unfamiliar, and we don't know people that do take part. So part of the reason for this talk is to kind of address the unfamiliarity element, to take the mystery out of it. Oh, there you go. Great. So here's some data. There's not much data in this talk. It's a very data light talk. But what you have there is a nice bar graph on the left, looking at the finding when we asked 910 people if you were asked to complete a health questionnaire as part of a research project, which would be important when thinking about taking part. So in the nice orange color, if they said yes to that question, unsurprisingly, people were saying, so almost 45% saying if it affected my working hours, that would be important to me. If it affected my family life, similar there, almost 50%. If it cost me money, almost 50% there, unsurprising. But the big ones that really stand out to me here, and we'll have a look at the free text responses, as we call them, on the right there in the text boxes, is if it could be risky and if I trusted the organisation, because these are things that are, I think, much harder for researchers to address. In working hours, you can make the research more flexible. You can increase the flexibility of completing a questionnaire, for example. You can let people take part in evenings. If it costs me money, more and more we're encouraged to reimburse people for their time. So again, you can cost for that. But the things about risk and trusting the organisation, these are much deeper concerns that I think will take some time to address. So we're looking at the quotes there. People are saying they really want an explanation explaining what will happen, the information I give, and how it is used. The other one, understanding what happens to my data. Where are you keeping it? Where's it going after I provide it? And the other one allows the participant to understand why their opinion and views are so valued, clear instructions. So, why me? Why are you approaching me about this research topic? And I think it's a really reasonable request. And again, as I say, as researchers, I think these are more challenging to address, but certainly possible and something we really need to be working on sooner rather than later. And I know for a fact we are working on them. There you go. So what we'll cover today, with all of that in mind, so we'll talk about what is health and care research and why it matters. We'll talk about the different types of research, so not just clinical trials, the other kind of research that's out there that may be more appealing to take part in. The role of patients and public in shaping research. How does research start? Like I can tell you from experience, you don't just jump straight in. So the ethical checks and the funding process, all very time consuming, very important. And lastly, we'll talk about research in the media. So I'm not just thinking papers and websites, I'm thinking social media and what a huge part that plays now. So first and foremost, what is health and care research? So how do we know what works in healthcare? Is it based on experience? Is it guesswork? Or is it something more reliable? And that's where research comes in. We ask important questions, we collect the information in a reliable, dependable way, we make sense of it, and we use the finding to improve decisions. And important, this is all done in a way that can be replicated or copied by our colleagues to see if they find the same result or they find something different. So it's done in a very rigorous, controlled fashion. So in terms of why it matters, without research, decisions would be based on guesswork. You'd hope some kind of consensus, uh, but you may end up with treatments that might not work well, might not work equally for everyone because those questions haven't been asked. Whereas with research, you end up with better treatment and care, more informed decisions, and improved outcomes for patients, which is what it's all about, really. So in terms of types of research, there are other types of research other than these three, but these are the main ones that I'm going to talk about today. So firstly, understanding people and experiences. This is what I've spent a lot of my research career doing. This is using surveys and interviews. Testing treatments and interventions. These are the randomized controlled trials, the big ones we often hear about in the news. And improving how services are delivered. So first things first, my favorite, understanding people and their experiences. So this is all about understanding what it's like to live with a condition, what challenges people face, what matters most in daily life. So when we do research like this, it's not just about understanding what it's like to have a specific disease. We also ask about what the experience of a treatment is like. Is the treatment is the cure worse than the disease, for example? Um, is taking a drug inconvenient? Are these causing problems in your day-to-day life? And are there things we can do? Um, Overall, it helps us ensure that care reflects real needs, the real needs of the person going through treatment. And of course, you can imagine this is particularly important in diseases where it's a long-term condition, a chronic condition. Now, in terms of testing treatments, um, this is where we start to think about the clinical trials, the randomized controlled trials, or RCTs, it's often abbreviated to. This is looking at, does a treatment work? Is it safe? Is it better than existing options? These are often very expensive studies, multi-million-dollar studies driven by large pharmaceutical companies. Um, I think you can tell me you can tell me if I've got this wrong when we get to the Q&A section, but to my mind, this is what people typically think of when they hear the word research. They think of drug trials. Now we're looking at improving services. Some research does focus on improving services. It looks at how care is delivered, um, whether access to the service is equal, or some people struggle to access it and others don't. For example, do young people struggle to access a service compared to older people? And what works in real world settings. So, for example, you may make a change to a service that tries to lower waiting times. I know waiting times is often on everyone's mind. Now, after you make that change, you need to record whether it's helped or not, or it's made things worse. And this is what this is all about. This is this kind of research. It focuses on making care effective and accessible. Accessible being a really big one. Great. Now we're going to talk about the role of patients and the public in shaping research. This is becoming increasingly important in research culture, and I'm pleased to see it. So not everything important can be measured with a test. You need to measure how people feel, how well they can function, how their daily life is affected. So two people can have the same blood test result, as an example, but can have very different experiences of the same condition. And that can be for a variety of reasons. Perhaps their priorities in life are different. Um, Perhaps there are other personal factors at play. Um, you know, things that can't necessarily be measured with a blood test. The patient voice is very, very important to research. Research can capture what matters to patients, experiences and symptoms, as we've talked about, impact on daily life, and priorities and preferences play a huge role in people's experiences of healthcare. And I think for a healthcare system to function properly, it needs to take those things into account and be able to adapt. So this helps ensure research reflects real-world needs. So in terms of how people can contribute, so I think we've talked a lot about taking part in studies, and that's absolutely true. Um, But more and more, we are asking people to share their experiences more informally in conversations, help design research projects from the ground up, and also help us decide what should be studied in the first place. And that's often done through something called PPIE, Patient Public Involvement and Engagement. And there are groups, PPIE groups, that are set up now to capture opinions. I rely heavily on the opinions of these groups to shape my own thinking about research and the results we should be focusing on when it comes to writing up our papers and what we should be putting on our websites. It's very, very helpful. It certainly helps keep things grounded and sensible, to be perfectly honest. So as I say, there is more to contributing to research than just providing data as a participant. So what I hope is becoming clear is research culture has very much moved on over the last 50 to even 100 years. We no longer conduct research on people. People are no longer just research subjects. And often you hear about that in when you watch old films and TV, they talk about research subjects. Now, the modern approach is research done with people. It's much more collaborative, often as equal partners and co-authors on publications, even if they're not part of the research team. If you're a part of a PPIE group, absolutely, you're making contributions. You should be a co-author on the paper. You can see the equal partnership there. It's where we're talking about research participants in this sense. So, how does research begin? Because if you get it right at the beginning, it's much easier to carry these things forward and continue to get it right. So before research begins, and it does not start straight away, I cannot emphasize that enough. Every study must go through checks to make sure it is safe, fair, well designed, and most importantly, worth doing. You don't want to waste people's time, particularly participants. So these steps protect participants and improve research quality. So the first step primarily is the sponsor review. So for me in my research, this is typically a university or NHS organization. And they ask, is this study well designed? Are risks understood and managed? Are the researchers qualified to carry out the research? And is the research feasible? Are you trying to do too much with too little money, for example? So the focus here is the safety. Is it realistic and is it well planned? And all universities and NHSs have a body that reviews research ideas specifically for this purpose, and then they give you feedback. Next, you typically submit to the Research Ethics Committee or REC. There are many RECs around the UK. This is an independent ethics review body, separate to the university or hospital. They ask, is the research fair for participants? Are people fully informed? And as a result of that, can participants give proper consent? They've had time to consider the information about the research. They've been given all the facts and the information they need. Are any groups excluded unfairly? So one of the big ones that often comes up is the need for translated documents. Is there a reason why you haven't translated? Can you justify that? Are vulnerable groups protected as well? There's always a balance. You want to include everyone, but you need to protect everyone that is taking part in your research project. So the focus here is protecting participants' rights, dignity, and well-being. It very much they protect and advocate for anyone that would take part in research. Now, looking at the Health Research Authority, HRA. Now, this is the body that specifically gives approval for research in the NHS. So they ask, can this study run safely in NHS settings? Are legal governance requirements met? And is patient data handled appropriately? So now thinking about those two last bullet points, because I appreciate throwing around words like governance isn't particularly helpful. But this is the body that will ask you about very much about GDPR. So that's the General Data Protection Regulation. This is the policy that came in from the EU. We've integrated it into our own data rules. So one of the big ones here is how long you can hold on to data for. From participants and how it's stored. You have to follow those rules, or the university is heavily fined. And they will make sure you're following those rules and you have a plan to follow those rules in any research document you send them. The other thing that catches people out and has caught me out in the past, I must admit, HRA will ask you, do you have an insurance certificate, an indemnity protecting researchers, but also protecting participants when you organising a research study, which is always an interesting one. And over time, you learn where those documents are saved on the university server, so you can upload it. But you can see here it's slightly different rule book, as I say here, governance focus compared to the REC. But overall, similar goals, making sure research is conducted safely. But the HRA, safe and appropriate delivery in real world care, very much is their focus. So all in all together, each step has a different role. Sponsor checks the study is well designed. The REC protects participants. HRA ensures it can run safely in practice. Together they act as safety nets. And ethical, safe, high quality research is what gets through. Now, funding research, I could spend our entire talk just talking about this, but I won't because you might not find it as interesting as I do. So it's as we've already talked about, the NIHR is the big UK funder, and they have their own goals and priority setting. But there are other funders out there. So research does need funding in order to happen. We do get paid for doing this work. Researchers apply for funding. Applications are very competitive, increasingly so, as budgets are restricted. Not all ideas are funded, and different funders have different priorities. So that means sometimes you end up compromising your research ideas and directions, and perhaps how you plan to conduct the research, perhaps reducing the scope of it, in order to hit the priorities and the budget restrictions of that research funder. There are other funders out there. It's not just the UK government or other governments that fund research. Pharmaceutical companies can fund research. So, for example, as we talked about before, a clinical trial, a pharma company may approach researchers and ask them to test out a drug for them. Because if a pharma company does its own research, it might be accused a bit of bias. The other thing that I've managed to take advantage of in the past is approaching pharma companies with my own research ideas. And it's referred to as an investigator-sponsored study, where you approach them with an idea, you have a discussion about it, and you see if it fits the kind of thing they want to fund. So you can approach it that way as well, which is very useful. But the main takeaway here is often, research is very research funding is very competitive. Your research idea isn't necessarily funded on the first try. There are setbacks. You do develop a thick skin, and it can take months or even longer to get the funding and get started. And that's before we even talk about contract negotiations with the funder and the amount of time that takes too. But I do consider this, I suppose, as another safety net. A funder will not fund poorly conceived research or unsafe research. So again, I do take comfort from that as well. So research in the media, as I say, becoming increasingly important. So the media is really important. I don't want to disparage it too much, and we are encouraged as researchers to engage with the media. You do learn how to write a press release, or at least a draft one, and then the professionals at the uni help put something together. They're very useful for raising awareness and sharing new findings, and encouraging public engagement. And one of the benefits of the popular press and social media is you may reach people that you don't typically reach through the normal channels. Not everyone goes onto a university website to see what they're up to, but they may come across something while they're online, a Guardian article that pops up on their phone or something. So it's useful for, uh, as I say, as a purpose of this talk to some degree, demystifying research if you see it in the popular press, and getting the findings out there, perhaps encourage them to take part in something in the future. However, there is always a need for caution. Headlines do not always tell the full story. Early findings may be uncertain. Again, we are encouraged to get our findings out there, even if they are preliminary results. But the enthusiasm by which the article is written may not temper the need for caution when interpreting preliminary findings. Complex results are often simplified, so of course there is a need to use plainer language when writing something that goes on the internet versus something that would go in an academic journal. And sometimes some of the subtlety of the finding can be lost in the popular press or on social media. Sometimes the word breakthrough or equivalent is used. Again, this is perhaps to generate clicks and engagement with the article, but that doesn't always mean proven. And again, there is I need to be cautious when reading these things. So all in all, summing up, research is about asking important questions. We involve people would be stuck without our research participants, and our research would be poorer if we didn't get the public engagement, the PPIE group engagement on our research. However, it's all about protecting participants who do engage with our research, protecting their data, not asking them things that are going to cause upset, and having plans in place if that does happen, and just being careful. And ultimately, it's about improving care and services. So, final thoughts. Everyone is part of research. Myself as a researcher, of course, but also the participants that take place, our PPIE group, public contributors, but also one message I would like to get across is whether you take part in research or not as a participant or as a contributor, the findings and the results will be applied potentially to you in the form of NHS policy or government policy. So I would encourage everyone to take part and make their voice heard. Well, thank you very much for listening, and I'm here if you've got any questions.
Thank you, Joe. That was brilliant. Hope everybody enjoyed that, and hopefully everybody now knows quite a lot more about research. So thank you so much for that really interesting overview. Right, so we're going to move on to the question and answer session now, and I'm just going to have a quick look to see what we've got coming through. Okay, so feel free to post your questions if you've got anything at all you'd like to ask to Joe. We've got about 30 minutes left, so we'll get through as many questions as we can in that time. Hopefully there'll be nothing too challenging for you, Joe. But we'll see what comes through. So we've got the first question that's come through already. So the question is, are there any criteria that govern which REC, I presume that's Research Ethics Committee, a study is sent to for assessment?
Oh, that's a very good question. Yeah, absolutely. There are RECs that focus on qualitative research. There are RECs that will help with a proportionate review of studies. So for studies that are deemed to be very, very low risk, they'll have a proportionate review and can be reviewed faster. There are also recs that will focus on children with research, for example. My research hasn't involved children, so I've not been able to use these. But because they specialise, they'll be able to guide and help with any potential concerns about consent from people that are underage. So yeah, there are rules in place, yes.
Great, thanks, Joe. So a few more questions rolling in now. So this is quite a long one, so bear with me. So this is from Warren. Thank you, Warren. You've summed up beautifully how research should work in an ideal world. As you move into the science of your own project, what's the one thing you're most excited to learn from us that you won't find in any of the safety nets or official reviews you've described today?
Oh, that's a good question. Um, some of the most useful information I've come across is from speaking to um, people with specific diseases, perhaps informally while recruiting them. You can't help but start a conversation with people when you're trying to recruit them for a study. And while we do more structured and formal qualitative research, these are the semi-structured interviews we call them, but it's a conversation that's recorded and analysed for themes. I do sometimes think the I do try and keep it light, but I do feel the formality of that sometimes puts people off speaking so openly and freely. So you asked me specific, what's the most exciting thing I'm um, um, looking forward to finding out about. I mean, I like to find ways to make sure the patient voice is captured as part of normal clinical practice. So my other research is looking at severe asthma and questionnaire data. So it's always nice to hear when that questionnaire has been used and the person in clinic feels it's been useful completing it.
Okay, great. So another really relevant and interesting question we've got from Miriam. Thank you, Miriam. What demographic have you lots of participants, and what demographic would you like to encourage? I think that's a
Oh,
really good question.
that's a very good question. It's very topical as well. I mean, we are growing increasingly aware that there is um, picking my words carefully here, but there is a bias typically in research data where people who are Caucasian from middle class backgrounds are those who take part and engage with research. Um, it's actually particularly bad in the very expensive um, clinical trials run by pharma companies where some of their data is 95% Caucasian. Now, there is absolutely nothing wrong with that in the outset. I think I will encourage anyone to take part in research. But of course, those findings, as I kind of hinted at in my closing line, those findings are then applied equally, they're generalized equally across society. So, regardless of ethnicity, regardless of socioeconomic backgrounds. And that's not a problem necessarily from a biological point of view. It's not. I'm not a clinical doctor. I can't see necessarily why drugs wouldn't work just because you're from a different ethnicity. I'm sure there are cases where that's the case, but not necessarily. But it is a problem when you consider, as I said, about accessing services, and the service may not be equally accessible, uh, from someone from a older demographic compared to a younger demographic, or someone who lives in a poorer area compared to a richer area. I mean, I know in the UK we talk about a postcode lottery, so that we need to be careful of. From my own research, I would say my on reflection, I did a lot of research in the Southwest, which is predominantly white British, so my data does have that same bias, but it's something I'm trying to address going forward. I'm very happy to talk about some of the strategies I hope to use going forward.
Great. Thank you, Joe. Another question. How long would it usually take for a study to obtain ethical approval? Are many studies rejected at this point, and can studies be resubmitted after amendment?
Thankfully, studies can be resubmitted after amendment. Um, so Yes, I covered three things, didn't I? I covered the sponsor review, the REC, and then the HRA review. So thankfully, the university, so the sponsor review or the hospital, uh, would not let you submit something they think is going to be outright rejected by the REC, which saves time because the form for the REC is longer than the form for the sponsor review. It also, is it's embarrassing for the researcher and it doesn't look good on the organisation, the university that's the researcher is employed by, if they're submitting something that's then outright rejected. In terms of time, I've had it was a questionnaire studies, just to give it some context. I've had questionnaire studies that have taken 3 to 4 months to get approval, and I've also had studies that have taken 4 to 5 weeks to get approval. Now, I think I had some bad luck when it was a very long approval time where the the rec was going through some restructuring, and we got caught out by that. But again, it's something you have to factor in. Factor in the initial submission, the time to write it, the time for the review, and of course the time to address any comments or suggested changes the rec or HRA may have, which of course has a cost implication, which is all very important. I hope that answers your question.
Okay, lovely. Thank you very much. There's two questions here which are quite similar, so I'm going to put them together.
Sure.
So do you have to be a doctor or professor to carry out a research study? Um, and then the other question is, how do you get into research and what qualifications do you need?
Oh, no, great questions. Thank you. So the first part, yeah, do you need to be a doctor or professor? No, absolutely not. So I was only awarded my PhD in 2000 November 2023, and I've been working in research since, or paid to work in research since September 2016. Um, so yeah, so about 7 years. Um, so effectively, if you're doing and this is kind of answering the second part of your question, effectively, if you're doing a BSc, an undergrad in BSc, and there will be Bachelor of Arts that also do research, have a research component, and you write a dissertation, and it's collecting data and it's writing up the findings. That is research. You're already doing it, and if you continue to pursue that and you show curiosity and intent to carry on, you can certainly progress to a formal paying job career in research. I would certainly encourage anyone thinking of doing that to then go on to do their masters, to collect more research skills, statistics, for example, and things like that, which they may have done in undergraduate, but just be more advanced stats. There are bottlenecks that happen where you may have a master's and you may be doing research and doing fantastic research, but you may struggle to advance in your career without the PhD. So, and for background, for people who do not know, PhD is the very academic research geared qualification, whereas the clinical doctors and your GP will have the Bachelor of Medicine and Bachelor of Surgery BMBS qualification, which is also use the title doctor, but it's not research focused, or there'll be a research component. It's more clinically and applied focused.
Brilliant. Thank you, Joe. Um, I like this next question. How is it decided which conditions or diseases are researched?
It's a good question. Um, there are peaks and troughs in research funding based on um, based on priorities. So I'll talk about. So I suppose more common conditions uh, will be more heavily funded, and more research will happen. That just makes sense. If more people are suffering from it, then it should be given a priority based on just being sensible and sensible use of government funds. So cancer, for example, has a lot of funding. Cancer UK is, I think, one of the biggest, if not the biggest, charities in the UK, and they they generate a lot of charitable funding and donations, and they also generate a lot of attention to the disease, which is very important. One thing that can happen, and I've seen this happen in my own respiratory research, is as new treatments become available for a condition, this is a bit backward actually, but as more treatments become available for a condition, the amount of research that happens increases. And that's because the new treatment may raise different research questions. So from my own experience, what's the patient's perception of this treatment? Um, is it practical to use it in clinic? Is there capacity to take on all these more patients now that you can treat everyone? So you can see where it works that way, but also the opposite as the drug development pipeline slows down in in the pharmaceutical industry, the funding can and does dry up. So it does, yeah, it does. You do have to be aware of that. It's yeah, almost seasonal.
Okay, great, thank you. So we've got more questions coming through. Um, so this is an interesting question as well. What type of study safeguards are in place for patients with limited or diminished mental capacity? For example, mental health problems, intellectual impairment, or even age?
That's a really good question. Um, so I have not done research on people meeting that criteria. However, I am aware that there are specific there's a specific group within the REC who will review applications who are wanting to do research with people meeting that criteria. Um, in terms of safeguards, from my own personal experience, we are required in our research. It's called a protocol. It's basically the set of rules you follow and how it explains how you're going to conduct your research. And we have to put in a section for what will happen in the event that someone we've recruited who's signed the consent form and we've understood that they have full capacity in the event that they no longer have capacity. So what happens in the event they're still providing data? So those things are thought about early on. It's not something that's made up as you go along. It's certainly planned for in the event that it does happen. And as I say, I cannot think of the name of it, unfortunately, but there is a specific um, group within the REC who will assess applications for people who want to collect data for people who may not be able to provide fully informed consent. Thank
Okay,
you.
thank you. Um, it's another nice question here from Warren. Thank you again, Warren. So he said, you've shown us how the university and the NHS act as safety nets. In a city as large as Birmingham, these institutions can sometimes feel like a fortress to the public. How can researchers like yourself use your excellent communication skills to break down these walls and make the research process feel like a truly open, two-way street for the community?
Oh, thank you. Um, I do. I think the fortress comparisons are really good way of wording it. I mean, you think about the University of Birmingham campus. You know, you don't see general members of the public walking across walking across the campus, even though they could. So it does feel kind of closed off. Um, or it certainly can do. I'll start by saying events like this are very helpful. And just talking about research, um, and as I keep saying, using the word demystified, but that's kind of what I'm trying to do. So trying to take the mystery out of the whole thing. There is a increasing emphasis on doing what exactly you've just described. The university website now, and the hospital website and the BRC sub website, I suppose, um, is aimed to be worded in a way that it's easily accessible and read by everyone. I was planning some text for the website um, recently, and I made some formatting changes because I was told that it wouldn't be compatible with an electronic reader for people with sight disabilities and or visual problems, which was something I hadn't considered before. But again, just shows the amount of thought that's being put into this. I appreciate you're not really talking about that. You're talking more about a cultural change. But I suppose I would just say that yeah, this is a priority to people, and I think more talks like this. There are community engagement days the university and the BRC puts on. Um, there's the exchange. That's what I'm looking for. There's the exchange in the centre of Birmingham that has a lot of events as well. So I'd encourage you to go on their website and have a look, and everyone to go on their website and have a look, where again research is presented in a nice, straightforward way.
Yeah, in fact, I might ask Becky, who's also on the call, if she could possibly dig out the exchange
Mm,
web address and pop it in the chat, because that might be quite nice for people to have a look at that. And you're right, there's an awful lot of activities going on at the exchange that showcases the research from the University of Birmingham.
Yeah, no, we're
Um,
getting there. Yeah,
yeah, yeah. Thanks, Joe. Still more questions coming in. Um, this is one about more sort of on the pharmaceutical company side. So, if a pharmaceutical study is funding its own research, for example, for a new drug, what measures are in place to ensure the results are reliable and not biased?
that's a good question. So they will, um, so they will fund doctors and other researchers who are not employed directly through the pharma company to conduct the study. That's one step. The people employed have an ethical obligation to um, conduct the research without bias and to present the data fairly. That really is drilled into you to do that and not get that wrong. Also, if you ever read a publication, even some of mine that are not big pharmaceutical funded studies or clinical trials, there's a disclosures section where they will where you basically disclose any funding you've had uh, that could be perceived as a potential bias for the results you've put out. The other thing that happens is peer review, and this happens um, in two ways really. One formally, one informally. So peer review, when you finish writing up your paper and you've got all the results in place and you've got the big long manuscript, you submit it to an academic journal, and it's then sent out. Assuming the editor is happy with it, the editor will then send it out to experts in the field who review it vigorously, and they will pick up on things if it looks a bit, if the data looks wonky, or it looks like things have been um, fudged, shall we say. So that's one way people will be pulled up on things, and that does happen. Um, the only problem with the peer review process is it's all voluntary. I'm asked to peer review papers all the time, and so you're not paid for your time of doing it. The other thing that happens is we are encouraged to present and to present our results at conferences. So this is either a poster, which I still think is a very strange way to present research findings, a big A0 poster, or if you're very lucky, you're given a talking slot for 5-10 minutes, which is tough. But again, people in the audience will, your peers, they will point out things that don't look right. So I'd say because of those two things, there is a rigor in place, yeah, to avoid any risk of bias interfering with how the data are presented.
Okay, thank you. So we're still plowing through our questions here.
Sure.
Um, so we have another one. This is about PPIE, so public involvement. So someone asks, some institutions still feel that ethics approval is required for patient and public involvement and engagement, especially with particularly vulnerable patients, as opposed to research participation. Could you please clarify?
Yes, yes, and this is when I was going through that, I felt I was could have been clearer on the distinction between the two, as in patient involvement versus as a PPIE level versus as research participants, where they give consent to take part in a study. So I think it is interesting. There is a lack of uniformity across organisations when it comes to this. Hopefully, there will be soon. Um, I completely understand, and I feel it's sensible that there is some um, ethical approval in place, or at least some checks to involve people who may not be able to give, who may not have full capacity to be able to give consent, to give their opinion. Um, but at the same time, it's a bit of a careful balance, isn't it? Because you don't want to stop these people from giving their opinion and excluding them from the research process. So, I mean, the University of Birmingham does not require formal ethical approval to conduct patient, public, and involvement and engagement activities, which I'm very grateful of. Neither did my previous employer. So I suppose I would just all I could say is if you do work for a university like that, I would uh, perhaps ask them why they require it and other universities don't, and how it's making perhaps your research uh, weaker as a result.
Okay, thank you. Um, there's one here about again, sort of touching on the pharma side of things. So
Mm.
hopefully this isn't too controversial, but what can be done to encourage more research and funding to be done for conditions where there isn't a lucrative pharma knock-on? Example, eating disorders and women's health. They continue to be hugely under-researched.
Yes, that's a very good question. So I know the BRC has a women's health theme, which is great, and
Mhm.
probably is a theme for that reason, if not among many other reasons. Um, what can be done? I suppose um, patient advocacy and explaining why these conditions, while they may not be, as you say, lucrative, cause burden that is, um, you may need to put a money argument on it. These conditions are causing burden that's preventing people from working, from engaging in education, and is limiting their quality of life, which is having a financial impact. The NIHR are aware of those conditions, particularly women's health, as we've talked about. Um, so there are people in your corner fighting that battle.
Yeah, brilliant. Okay. We might just have time for one more question before we've got to wrap up. Um, so there's a question. I mean, I think you've touched on this actually a little bit, but it'd be nice to kind of answer this specific question.
Sure.
So this person asks, many research projects are only performed on males or animals, which can cause a problem when applied to women, such as medications and cardiovascular studies. They're supposed to be carried out on females as well, but that doesn't always happen. The question here is, are your studies on females as well as males? Which I'm sure they are, Joe, but you might want to comment more broadly on, again, it's that diversity, isn't it? Making sure that we have in a really good distribution of diverse participants.
Yes, yes. It's interesting you mentioned cardiovascular research. So I know, um, so for years and years, the last 30 to 50 years, um, heart attacks in women have always been described as presenting atypically, which is a fancy way of saying, they don't present in a normal way. Uh, but it turns out, and I'm sure people in the audience know this already, it turns out it's because the research and the understanding of how heart attacks present has only been understood in men. So it may be, so it just shows where you have to, if you're going to apply research, it needs to be using data from from a representative sample. So that's yeah, a bit of a tangent there, but it's a good example. Um, my own research, starting with that one, has been conducted in men and women. A lot of my research, uh, as I say, was in severe asthma, which pre presents mostly in women. There's about a 60 60%, 40% split, with more women presenting with severe asthma. Um, and in terms of overall, I think you are right. I think um, women who are pregnant, of course, are excluded from most drug studies, if not all drug studies, because they don't know how the new drug is going to affect the development of the fetus. But then, of course, as we've seen recently, there's then a lack of data out on the safety of taking the drug when if you're a pregnant woman. So yeah, so it is very difficult. I think more does need to be done, and I think the culture is shifting.
Okay, brilliant. Thanks, Joe. So we're rapidly getting towards the end, towards 7 o'clock, and there was just a couple of things I wanted to finish off with before we close. So Jo, you're off the hook. I think there'll be no more questions now. So thank you so much for answering all those questions so excellently.
Thank you.
So I just wanted to say to our audience members that if you've enjoyed tonight's talk, and if you're not already, but you think you might be interested in getting involved in research, just wanted to let you know that there's a number of ways that you can do that. Joe's touched on some of those throughout his talk, but we just wanted to recap on those. So you might want to take part in a clinical trial or in a study, so actually be a participant in the study. And there is a national website that you can see on the screen now called Be Part of Research, which is actually run by the BRC's funder, the NIHR. And you can register on this website and find out all the different studies that are happening all over the country and have a look at the details to see if that's of relevance and of interest to you. And then you can apply to take part. And I think Becky's putting the link to that in the chat as well, so you'll be able to see how to access that. Another way is to get involved in research, which is slightly different to participation. And it's worth saying that this webinar series that we're running now is a result of us working with our amazing public research partners, or members of the public, who we're always very grateful to, and we thank them for their time and their contributions. And at our research centre, at the Birmingham Biomedical Research Centre, we involve and engage with the public and our local communities in lots of different ways. And we're always looking for new people to join us and get involved in our studies. You can see on the screen now some of the ways that we kind of go out into the community and try and talk to people about research and getting them interested in taking part. And your own lived experience of having a health condition or perhaps caring for somebody with a particular health condition is really important and can make a huge difference to research. So there are lots of different ways that you can be involved in research that suit your own preferences and your own commitments. It can be as much or as little time as you can spare. If you would like to find out any more about that, again, I think Becky's going to put a link in the chat, and you can find out a bit more about the opportunities that are available for you to get involved in. We do send out a monthly newsletter from it's called the Birmingham Public Involvement Hub, which is a collection of research centres working together to encourage people to take part, to be involved in research. And this newsletter will give you lots of information about different ways to get involved. So if you are interested, that's another way that you can find out a little bit more. And you might want to join one of our public involvement groups. So again, there'll be another link going in the chat, which tells you about the existing groups that we have as part of the Biomedical Research Centre, including one that Joe currently looks after for patient-reported outcomes. And I know you're recruiting at the moment, aren't you, Joe, for new and diverse members? I know you've had a really good response to that, so that's fantastic. But again, you can have a look on our website. You'll be able to see all the different groups that currently exist and if there's anything that you might be interested in. Some of them aren't always recruiting, so some of them are quite popular and they can be full at times. But if you're interested, please do drop us a message and we can try and find out if there's any opportunities for you to get involved. So that just leaves me to say thank you very much to Joe for giving us an excellent presentation tonight and answering all those questions that just kept flowing through. So thank you so much for doing that. And a huge thank you to all of you for joining us this evening. Really hope that you've enjoyed it and you've got something out of the talk. We'll be holding our next talk in May. I think I've got the date on the next slide, actually, on the 5th of May, same time, 6 till 7. And that's going to be with Professor Neil Morgan and Dr. Jana Mistry. And we're going to be talking about bleeding disorders. So that's, again, as completely different area that we've not covered so far in these webinars. So hopefully you'll register to come along to that. And again, I think Becky's going to drop the registration link into the chat for you. And finally, just to say, we'd love to hear your feedback. Thank you to everybody that has been to previous webinars and provided your feedback. It's really helpful, and it helps us to keep improving and trying to change our webinars as we go forward. It's really quick. It only takes a few minutes to fill in. So if you can spare the time, we'd be really grateful for you to fill in that form. And again, Becky will put that in the chat. So there's going to be quite a few links. Um, After tonight, this recording will be shared with everybody that has joined and everybody that registered actually and couldn't make it. And Becky will share some of those links that we've talked about tonight as well. So you will get a chance to receive those by email. So thank you, everybody. Thanks again to Joe. Hope you all have a lovely evening, and we look forward to seeing you again at the next webinar. Thanks,
Thank you.
everyone.
Bye.
Bye.